there are 6 subjects in the final MBBS, it will be not the problem. This exam actually, it was for rehearsal of, and you have already known in the meantime how will you have to appear and how to prepare. And enjoy the reading and the training, and always interact with your teachers. And there is no seniors here, that is the problem, but there is also advantage also. There are advantage also. Always interact with the teacher. 2 things you will learn. Number 1 is the first of all is the to make yourself prepare for the future practicing of like that. This is the noble profession. And second, definitely to good scores in your exam. That is very tactfully you have to do, and selectively you will have to do, because 6 subjects which is not possible for for coming 6 months. Everything to do, but you will make good result. I hope and expect. It will be not the problem. Now we will have to concentrate in your reading of the bit, particularly the clinical, all of clinical subject, the clinical programs. Today, there is a very interesting topics and important topics, that is secondary amenorrhea. A few months back, I had planned to secondary amenorrhea together with the primary amenorrhea or secondary amenorrhea. And primary is you have read it very well, primary amenorrhea. So many of the cases illustrated. That is the not so much common, but the problem is the secondary amenorrhea. Not actually the secondary amenorrhea only, that is the oligomenorrhea. I will go into detail. And this is the day-to-day problem. And in general practice you will get, and gynecological practice you will get. And first of all, I will just start with the case scenario, small case scenario. Then we will go to the what do you mean by secondary amenorrhea, oligomenorrhea, and what are the important causes you will have to know, and how will you investigate and outline the management. This is a vast subject actually. So, and polycystic ovarian syndrome is the common cause of the oligomenorrhea. So, I will show, this is not the class of the polycystic ovarian syndrome alone. So, we have to cover everything. That is the another class was allotted. I think all of you done the discuss. So, I will highlight which are important for me. So, you see, a 20-year-old woman attended to a clinic with complaint of irregular periods, 22 years, with infrequent cycle and excess facial hair and few facial spots. The patient. She also tells that she has gained 5 kg of weight last 1 year. Now her BMI is 30. She tells that she has consulted her house physician, and house physician has advised her to do pelvic ultrasonography. Always what is done is a very common thing, the pelvic ultrasonography, right? Do the pelvic ultrasonography. It was found that in USG report, the majority of the USG report will say at this age here, there is a polycystic ovary. May not be the syndrome, the polycystic ovary. It has been. So that is the girl is really very worried. So she is saying, I have gone through the internet and seen that there are a lot of problems of the PCOS in the internet. There are so many adverse effects like that, including the children issue, fertility issue, and also various health issues, long-term effect, like the hypertension disorder, cardiovascular disorder, diabetes, even the endometrial carcinoma. She has written so I am very worried. This is the common scenario. We will get in practice, day-to-day practice. This is a very, very common scenario. But as a clinician, what will you do? That is the very important. He has come. He is very worried and a justification of worry. What will you do? That is, you first, two things you will do. Number one, you explained about the disease. And at all she is suffering from that severity of the disease. You will have to judge. And second important thing is, if at all occurs, it is a very serious, it is a really diagnosed case of PCOS. You will have to explain, you will have to counsel. All the adverse effects can be controlled and pregnancy can be achieved. That is the follow-up is disease. So, how to reach this is really a polycystic ovarian syndrome. I have started with the polycystic ovarian syndrome. This is the commonest cause of the oligomenorrhea. The next cause is that is ovarian cause, and next cause is the hypothalamic cause. Other uncommon cause I will also describe. Thoroughly history taking and examination is very important. I will go how you take the history. Exclude the other causes of the delayed puberty. Any other medicine intake. Some medicine like oral pill and also the phenothiazine group of drugs that may cause hyperprolactinemia, amenorrhea. There are some other drugs. I will mention what are the drugs. Particularly, she is taking some anti-epileptic drug. Whether she has exposure to polycystic on pregnancy, always when there is a delayed period, you will always have to think about the pregnancy. Always about the think of the pregnancy, and she may confess you the actual what is the fact actually, really the sexual exposure. Well, you will have to ask. The majority of the cases, particularly the adolescent group, teenage group, unmarried girls come, and mother will tell them there is no such history. Mother, no, আমার মেয়ে এরকম হতেই পারে না. That may be separate thing, but you always ask very tactfully, because if there is chance of pregnancy in unmarried 17 years girl, 16 years girl, there is some social problem. So you will be very tactically, you will have to take the history, but you always remember that may be cause. In a delayed period. Next is what is the degree of the hirsutism? Hirsutism means excessive growth of hair, facial growth of hair. You write down all the questions, and at the end you will ask me the questions. Definitely it will be interactive. When it will be interactive, I will do. Ask. Hirsutism, do you know the hirsutism? There is a grades of the severity of there is a scoring system. You will have to do score. Normal hair is not so uncommon. Normal excessive growth of hair is not so common. They are not always hirsutism. And another thing is the pimple or the spot. It is very, very common. There are some physiological. It is very common. So you have correlate. The girls will correlate with these. So I am suffering from PCOS. The sleepless night, also her and also for family. That is the problem. You will have to stand by at that time. Don't jump into so much of investigations. Don't jump. So much of investigation, you don't jump. And next is examine the sonography report meticulously, because the small sum cyst, small sum follicle are common in the sonography, pelvic sonography. That doesn't mean always the polycystic ovarian syndrome. There are some criteria. At least the 10 to 12 follicle, and what is the diameter of the follicle. So you will have to, if you think you always repeat one ultrasonography for a good sonologist. That is very important. That is the main problem of practicing of our profession now. any girl comes with the report with the polycystic, everyone is suffering from it. It is not so like incidence is not so high. Incidence is not so high, but not uncommon. Exclude the hypothyroidism and hyperprolactinemia. That is the common cause of the amenorrhea. Exclude irrespective of the polycystic ovary syndrome. So even it fits the polycystic ovarian syndrome criteria. There is the PCOS. At last I will show there are the criteria. There is the basic 3 criteria actually, and there are 1990 classification, 2003 classification, and the latest classification of the Hyperandrogen Society. And all of you know the polycystic ovarian syndrome that has been described long back 1937 with 7 cases of the polycystic ovarian. But still 11th, you will go to your department and there is some poster of the still 11th and the story has been told there. You read that in your department in the Baranda department. I have go to the still 11th syndrome. But still the polycystic ovarian syndrome is many things we do not know, and unknown to the literature and unknown to the medical literature. Now, asked to arrest the increase of the weight, that is the increase of the weight. If the increasing weight, asked to arrest. And even if the excessive weight, you reduce the body weight and BMI. And lifestyle management, diet and exercise at least 3 minutes. At least 3 minutes in day. You do the exercise, 30 minutes, I am sorry, 30 minutes. At least 30 minutes in day. You practice. At the beginning, you ask to practice it the 15 minutes, then 20 minutes, 30 minutes. But with a regular habit, you will get the benefit, the exercise and other physical exercise. But you are very lucky from the, if you think of some problem there, your girl's hostel and the hospital is far away. So walking is not the problem there. So it is the force walking. So that is very good for you. Sometimes you will think that is I will have to walk, but this is very good for you, good for of your health. And select the appropriate medicine that regulates cycle, decreases hypertension. Appropriate medicine, and some of the drug actually that will select medicine regulate the cycle. That is one cause of worry, and hyperandrogenemia disease. And definitely the first line is the oral progesterone combination pill, that is the oral contraceptive pill, but the oral contraceptive, and that will some less androgenic progesterone. Ethylene acetaldehyde is the constant, but progesterone to select the less androgenic or maybe anti-androgenic. Counseling and regular follow-up, that is the I told the first. So this is the scenario, and this will get in practice. Now, traditionally, amenorrhea is categorized as the primary and secondary. All cases of the secondary amenorrhea may be called primary amenorrhea. All cases of, or if the secondary amenorrhea causes occurs in the prepubertal age or peripubertal age till menstruation, that will cause the primary amenorrhea. And how to define secondary amenorrhea? Secondary amenorrhea is the cessation of the previous regular menses for 3 months or previously irregular menses. This is the definition. This is nothing but the definition. 3 months regular cycle and 6 months irregular cycle. So that is the secondary amenorrhea. Is the in the literature is the definition. More common is the oligomenorrhea. More common is the oligomenorrhea. You will wait for the 3 months. So amenorrhea will not do nothing. So oligomenorrhea is how to define the oligomenorrhea. Normally the cycle varies from 21 days to 35 days. 35 days. Oligomenorrhea, the cycle interval is more than the 38 days. Cycle interval is more than 38 days, and it may be irregular, sometimes irregular. And causes are like secondary amenorrhea. Cause and all the secondary amenorrhea. And when to investigate? In women with regular menstrual cycles, a delay of menses for as little as 1 week, you always exclude the pregnancy. Yes, sir. If there is a doubt about the sexual exposure, doubt about the patient, doubt of the confident, no problem. And secondary amenorrhea lasting from 3 months and oligomenorrhea involving less than Nile cycles per year. Usually, the Nile cycle in 12 months there may be 9 cycle. You expect the 12 cycle normally 28 days plus minus 2. So 12 cycle, but if it is 9 cycle, there's no problem. No need of urgent investigation until unless there are some indications. So suppose 7 cycle, 8 cycle, this is common problem actually. This is a very, very common problem. In which case you will investigate. Even if the cycle is number of cycle is less in the 1 year, there may not be always pathological. And when one is authorized, but you will have to investigate to exclude pathology. Now, this picture I have shown you 2 times. One is the physiology of ovulation menstruation and the primary amenorrhea. Menstruation is the end result of the hypothalamic, pituitary, ovarian and uterine axis. If a menstruation is there is a menstruation at the pivotal at the approximately that it can be the tract is normal, and also this is regulated by the something like the normal karyotype mixed turner, and there may be menstruation also, but abnormality the karyotyping, the mosaic turner, and also the normal thyroid, normal adrenal and nutritional metabolism. So when there is a problems of primary amenorrhea or secondary amenorrhea, you will think always this may be the cases. But what we will see in our practice actually, that is also very, very, very important. Etiologies of the secondary amenorrhea. I have already said the commonest group lies in the ovarian group, that is about 40%, and of them the polycystic ovarian syndrome is the major, and premature ovarian, and so the premature ovarian failure, literally it is called when the menstruation ceases, the menopause occurs, is less than the 40 year, that is called premature ovarian failure, and recent name is the premature ovarian insufficiency, POI or POF. In practical sense, it is 35 years, but the literature says is the 40 years, the definition, the premature ovarian. And other causes is the hypothalamus. And hypothalamus, some are the really some very vague causes. So it is not always possible to determine what are the causes, because you will see the causes actually, the psychological, and the psychology is very important. Suppose in front of exam, stress and strain, that may cause also the delayed period, and even the marriage, that may cause also the delayed period, and and also some antidotes also. But these are the psychological is the important factor. Psychological, stress, strain, and the psychiatric illness, and dieting. More diet causes the obesity and maybe the oligomenorrhea, and less diet, that is vigorous dieting you have started, that may cause also amenorrhea. So you will have to balance, and vigorous exercise, and chronic debilitating disease, and pseudosciences and drugs. Some drugs, I will mention also the drug. The pituitary is the important factor and the treatable factor, 19%. That is the pituitary adenoma, the prolactinoma, and Sheehan syndrome. Have you any idea about the Sheehan syndrome?
Pituitary apoplexy. Pituitary apoplexy due to PPH.
The pituitary damage occur, necrosis occur. So the earliest sign symptom for following postpartum hemorrhage, lactational failure. Then you do the CT scan. That is the Sheehan syndrome. It is very important for your short note also, the MCQ, everything, the Sheehan syndrome. And the Cushing's disease, not so common. Uterine cause, that is the tuberculosis. In our country, tuberculosis is the important cause. That is the secondary amenorrhea tuberculosis. And sometimes that is the synechia. Synechia, what happens even the vigorous curating you are doing, Indian operation. So endometrium to totally loss, there will be adhesion anterior posterior. The synechia. There will be no endometrium for bleeding. Other endocrine disorder. The important is the thyroid. I have already said thyroid. You exclude thyroid and exclude the adrenal disease and pancreas. And common causes, this is the very important picture. You say the common causes is the PCOS, hypothalamus, and the pituitary adenoma, and uterus, and other causes. So these are what are the common causes of the secondary amenorrhea. That may cause also the oligomenorrhea also. Oligomenorrhea may present you as oligomenorrhea. When symptoms of the hyperandrogenism are evident, hyperandrogenism is the evident, then you will have to think whether it is PCOS or not. The most important criteria is the Rotterdam criteria, that is the acceptable criteria 2003. There are three things in the criteria. You remember very attentively here what I have listened, I will say. Number one is the features of the oligovulation and anovulation. How will you know? That is only if there is a normal menstruation, normal ovulation may be expected. But if there is the oligomenorrhea amenorrhea, that may be ovary has two functions. One is the ovary has two functions, the production of the oocyte, and another is the hormone. So these are really interrelated. So that is the indication oligomenorrhea amenorrhea, that is maybe the oligovulation and anovulation. And second is the features of the hyperandrogenism. That may be biochemical, that may be clinical. Suppose really the excessive growth of hirsutism, and the excessive acne, or like the baldness, and alopecia. Alopecia is one of the feature of the really surprising. What is you will say in common practice? The androgen hormones in the female, if you give, there will be the excessive growth of hair in the body and face, but there may be alopecia. That is the loss of hair. That is the common. The contradictory action of the androgen in woman. And PCOS is and third thing is the polycystic ultrasound will be polycystic ovarian syndrome. Ultrasound polycystic ovarian syndrome. They show the polycystic. There is a definite any two. That may be a patient woman. If there is no ultrasound is normal, that may be also the polycystic ovarian syndrome. And also there is no hyperandrogenemia, that may be polycystic ovarian syndrome. Another two. But that is why it is said now the androgen excess society, they have said the hyperandrogenemia will be the constant feature to diagnose the polycystic ovarian syndrome. The third criteria, recent criteria, that is. Now come to the another thing is the disorder of mental and metabolic wellness are considered in individuals who have previous normal menses. Mental and metabolic, sudden changes, dramatic changes in the body. Medication and drugs causing secondary amenorrhea. These are the important medication taking history will take. That is the anti-epileptic drug and any steroid hormone, injectable contraceptive. After pill withdrawal, there will be, and the phenotharase, metoclopramide, and pantoprazole. And always many people take the pantoprazole, PAN-D like that, always. But that may cause also the galactorrhea, that is the hyperprolactinemia. These three drugs cause the and chemotherapy and the addiction, heroin and cocaine. The physiological causes of the anemia, physiological cause. Important physiological consideration of the anemia, the pregnancy, lactation, and menopause. Pregnancy, lactation, and menopause. So we will have to, in the perimenopausal age, we will have to take history whether she is achieving the menopause. But that is another age. That is another time. There is a chance of accidental pregnancy. That the accidental pregnancy at that time is the perimenopausal age. Now, pregnancy test must be the first consideration in the secondary amenorrhea, and false negative. Sometimes there may be the false negative. The kit you have been supplied, that may not be always right. So, if any doubt over the patient, you do another thing. I have seen so many cases. the pregnancy is negative. But I have asked my postgraduate to do another from another company kit. That is the positive. But I was confident about some ectopic pregnancy like that. I have seen the negative, but another kit is the positive. So always check everything. You will check, and don't blindly rely treatment, particularly the treatment on relying on the investigation report. The clinical thing, what you will think, that is very important. The recheck. And with the expanded Rotterdam criteria for the PCOS and increased prevalence of obesity, more patients may fall into the PCOS category today. This is the very recent article published. Now evaluation, that is you see, the how you will do it. History taking, clinical examination, like any clinical case. History taking, clinical examination and investigation. History taking age, near menopausal age, you may think that may be the menopausal, perimenopausal age. Menstrual history, details of the amenorrhea. And you take the menstrual calendar, and invariably will see the patient will not be able to give you the menstrual calendar. On that she has come, you write down the menstrual calendar. Which date is the onset? It is the onset. It is the onset of the menstruation, which date and what is the duration in every month. And 6 months to 12 months you see, you will get an idea what is the actual, what is the physiological or pathological. That is, and hot flash, loss of libido, and the vaginal dryness due to either menopause or POE. Excessive growth of hair, acne and alopecia and PCOS, and adult onset congenital adrenal hyperplasia. When there is a hirsutism, the commonest cause of hirsutism is the polycystic ovary syndrome. And the second important is for the MCQ also, and also commonest cause is the polycystic ovary, and another is the congenital adrenal hyperplasia, adult onset, and third is the androgen secreting tumor, and mostly the ovary, adenoblastoma, androgen secreting tumor, or it may be the adenylum gland. So three things you will remember the hirsutism. For the excessive growth, for that cases, in case of another polycystic ovary syndrome, the growth will be abrupt. If there is a malignancy, that is called virilization. Virilization and hirsutism, there is some difference. Hirsutism is only the growth of the hair. Virilization is the extreme hirsutism with upper other features of the virilization. There is the hoarseness of the voice, atrophy based, and baldness, and even there will be enlargement of the clitoris. That is the enlargement of the clitoris. That is the virilism. And virilism occur only 1% in case of hirsutism. 1% in case of hirsutism. And headache and visual defect. Because that may be due to the pituitary adenoma, the hyperprolactinemia. That may be micro and macro. Headache and visual. You ask if there is a case of lactation, always ask, তোমার কি হেডেক হয়, তোমার কি খুব হেডেক হয়, চোখে দেখতে কোনো অসুবিধা হয়, that is the extreme case actually. This is the extreme case. And history of weight gain and weight loss, anorexia nervosa, there will be amenorrhea, and also the vigorous exercise. History of galactorrhea is very important. It's always amenorrhea or take the history of the galactorrhea. Galactorrhea is the non-milky discharge from the breast. What do you mean by galactorrhea? It's not milky or not purpureal, not actually the non-purpureal. It may be white color, it may be transparent color, galactorrhea secretion. Usually in case of hyperprolactinemia, bilateral occurs, galactorrhea. It's very important thing. Obstetric history is important. The postpartum hemorrhage, the lactation failure is the first, and second is the whether the patient is already in lactation. 2 years past, the baby is taking milk. That is lactation and amenorrhea. That may be lactation and amenorrhea. Well, always exclude pregnancy. And abortions and synechia. Past history, medical heat or cold to the thyroid. There may be heat or cold intolerance, sleep disorder in thyroid, psychiatric illness, pelvic infection, and tuberculosis. History of tuberculosis in our country. Surgical history of the DCM. And family history, sometimes particularly the premature ovarian failure or premature ovarian insufficiency may run in the family, ফ্যামিলি, দ্যাট ইজ ভেরি ইম্পর্টেন্ট। তোমার মায়ের কি মাসিক অনেক আগে বন্ধ হয়ে গেল, যদি 35-36 হয়, তখন মা তো অনেক সময় থাকে সঙ্গে, তাকে জিজ্ঞেস করতে হবে। দ্যাট মে বি প্রিম্যাচুর ওভারিয়ান ইনসফিসিয়েন্সি। And it is now recently said the polycystic ovarian syndrome, some genetic predisposition, polycystic ovarian syndrome recently. And drug history, I have already said, antipsychotic and metoclopramide phenazolidine causing the hyperprolactinemia. History of radiation, radiotherapy, contraceptive history, postprandial amenorrhea, and the injective. Now, clinical examination, height, weight, BMI. If the low BMI cause amenorrhea, oligomenorrhea, high BMI cause the oligomenorrhea. Or obesity causes the itself of the and hirsutism, acne, balding, and hair and syndrome. Hair and syndrome, hyperandrogenism, then বল কালকে আগে দিন বললেন hyperandrogenism, কালকে ওপিডিতে কে কে ছিল? হ্যাঁ, ইনসুলিন রেজিস্ট্যান্ট, অ্যান্ড থার্ড হ্যাঁ অ্যাকান্থোসিস নাইগ্রিকান। এটা কিন্তু সবসময় মনে রাখবি, হেয়ার অ্যান্ড সিন্ড্রোম, গাছ থেকে পড়বি না। ইট ইজ ওয়ান short note, one MCQ, everything, and associated with the hypertension and typical polycystic ovarian syndrome. And enlarged thyroid gland, delayed reflective bradycardia hypertrophy. Patient may give you that there is no gonadotrophy, but when you will examine in presence of women or sister, ask the sister to compress the breast, whether there is a galactorrhea, just nipple, breast, whether there is a galactorrhea. And supraclavicular Cushing syndrome, uncommon, and the abdominal examination lump usually may be the ovarian tumor, adenoblastoma, androgen has a lump, secondary amenorrhea. Primary amenorrhea there may be other causes, and vulval vagina, pictures of estrogen deficiency, pictures of dryness, and uterus always do the pervaginal examination, and if it is unmarried, particularly if it is unmarried girl. And hair and syndrome, that is the typical feature of the hair and syndrome. I will show another picture also. The hyperandrogenism, insulin resistant, and confusion. This patient comes with amenorrhea and oligomenorrhea. Sometimes amenorrhea 3 months, 4 months, and sometimes the only oligomenorrhea. The investigation, first investigation are already explained. Don't jump into the so much investigation. Initial investigation, you will do the TSH, prolactin, FSH, and estradiol. TSH prolactin, then FSH estradiol. I am coming when you will do estradiol. And estrogen status, that is very important. Estrogen status is very important. If so, there is a estrogen status is good, that means the ovary is active and there is no ovulation. So estrogen status, how will you see? That is actually the main theme topic today, How will you see the I'll in detail how will you see the estrogen status? Only by, not by any invasive procedure, not by some invasive procedure. Only by some small investigation you can do. You see, there is the ovary is working normal. That is the particularly polycystic ovary is what has happened. It is not the premature ovarian failure, not the ovarian failure. And next, that is the progesterone challenge test. Serum estradiol, endometrial thickness, and cervical. I am coming in details to blood biochemistry to any systemic disease and suspected cock. Cocks in the meantime, medicine always think of the cock. Usually there is a past history of cock in female. The X-ray test, Mantoux test, and other tests, you know better than me. And serum testosterone, particularly hyperandrogenism, the testosterone, and that will say the polycystic ovarian serum testosterone may not be elevated or mildly elevated, but in case of adenoblastoma and adrenal gland tumor, that will be high serum testosterone. And then DHESO4, that is increased in case of adrenal gland and adrenal hyperplasia. And ESG pelvis and abdomen in lot of investigation. Now investigation, but it should be done a very good sonologist. It should be done always very good. You can see the morphology of the ovary, and also if there is a tumor or like that, you can the adrenal tumor or the ovarian tumor, you can learn that. And the CT and MRI brain, if you suspect the prolactinoma, do the CT MRI for the brain and to exclude the tumor. Now, approach to the diagnosis in the case of the secondary amenorrhea. Before approaching, I will just do the reproductive physiology of the menstruation. Why does menstruation occur? That is those. So then you will pinpoint and you will be able to identify the why there is amenorrhea, why that menstruation occur. I took a I can remember I had taken a long class for the physiology of the menstruation, physiology of the ovulation of your batch. I can remember, but you may not remember all the thing. So just recapitulate. What happens actually? What is menstruation? Menstruation is the cyclical shedding of the functional layers of the endometrium. Initially manifested by the cyclical bleeding per vagina due to ischemic necrosis of the endometrium. As a result is the withdrawal of the estrogen and progesterone. So it is always occur, and the endometrium is ready always to prepare the endometrium, so that implantation occurs. Endometrial bed is preparing, and that is there are the hormones, different hormones, and that is the ovulation occurs. After the ovulation, the progesterone comes and take the main responsibility. Take the responsibility to prepare the home for the endometrial bud for the who is the to welcome the guest, that is the fertilized site, that is to welcome the guest. That is the progesterone. So there is some interaction of the progesterone. First, before ovulation, that the estrogen means the take part. Mainly the estrogen. You see the picture here. Before ovulation, estrogen takes the main part before ovulation, and after ovulation, what happens? There is the ovulation. The progesterone is secreted, and before ovulation, the estrogen actually great role to welcome the progesterone to make some receptors also. There is a receptor, and when progesterone comes, estrogen causes the proliferative endometrium, and when the progesterone comes, it actually destroys the estrogen of the receptor of the endometrium, and the secretions occur. The food store makes. সেজন্য ও করে কি ইস্ট্রোজেনকেই খুব একটা কাজ করতে দেবে না, যদিও সেকেন্ড হাফে ইস্ট্রোজেন কাজ হয়। কারণ আমি একটা কথা গল্প করি সব সময় যে ইস্ট্রোজেন ইজ দ্য গুড ফ্রেন্ড অফ দ্য প্রজেস্ট্রন, or progesterone is the enemy or bad friend, you can say, whatever. Estrogen also required in the late phase. This is actually the scenario. That is actually the scenario. And when there is no implantation, if there is implantations occur, what will happen? There will be drop of the estrogen and progesterone, and corpus luteum will be digress. As the estrogen and progesterone, you can see here, as the estrogen and progesterone, estrogen drop, so there will be again the FSH will be decreased. That FSH will again recruit the follicle here, and the follicle will elaborate there will be secreted of the estrogen. That estrogen form the proliferative phase. That was the proliferative phase. And as the estrogen becomes high, so there will be LH surge. And LH surge will cause actually the ovulation, trigger the ovulation, LH surge. So if you go to the hormone level, I am not going into detail now, where there are so many remainings to describe. Very interesting things. You read this, you draw this picture. Everyone, you draw this picture. You will learn many things, and it will be very beneficial for future. And what will happen? The progesterone comes, and progesterone causes the secretory endometrium, and the corpus luteum secretion, both mainly the progesterone. So these cycles occur. So if you just go through and recapitulate the hormone changes. What hormone changes? FSH, LOH, estrogen, and progesterone. The hormone. What is the and second is the ovulatory cycle, 14 days. In 28 days cycle, 14 days, there is the 14 days. In 28 days cycle, the 14 usually, not 14, that may be 12, there will be 13, that may be 15. But there is ovulation occur. And this is the proliferative endometrial cycle, proliferative phase, and the secretory phase. So why menstruations occur? Menstruations occur as there is the estrogen progesterone drops. So what will happen? There will be necrosis of the endometrium. That necrotic and withdrawal bleeding occurs. Withdrawal bleeding occurs. And then the withdrawal bleeding, that is the menstruation. Menstruation occurs. Suppose there is no ovulation. That is the topic today. What will happen? There is the ovulation. What will happen? So estrogen takes the upper hand. Always estrogen is secreting. What is the function of the estrogen? Proliferation of the endometrium. So proliferation is becoming thick, becoming thick. But at one time, after certain period, suppose the 40 days, 45 days, or like that, there will be excessive bleeding. And there will be excessive bleeding. Patient is suffering from oligomenorrhea amenorrhea because there is a proliferation, so there is excessive endometrium. So there will be excessive bleeding, anovulatory bleeding. But this is the typical picture. Oligomenorrhea, have you understood everyone? Have you understood everyone? This is very important thing. Typical picture of the polycystic ovarian syndrome like that. Then the endometrium proliferations occur, and after that, as the endometrium is thickened, so there will be the uterus cannot hold so much of the endometrium. So normally there will be the shedding of the endometrium and the excessive bleeding. Not limited to the 5 days. The menode is there a heavy menstrual bleeding amount and also the duration. So this is it. And again our oligomenorrhea. So this is the picture. So your aim as a clinician will have to control the cycle, control the symptom, and the patient wants child will have to drug so that the ovulation. This is a simple thing to control the sanction, and estrogen progesterone field has a great role in the first line in PCOS because it is also reduced. It reduces the hirsutism. That is the sex hormone component, not hirsutism. One totally cannot what the hirsutism has occurred cannot revert back. But SHBG, sex hormone binding globulin, it increase from the liver, and androgen will bind. So hyperandrogenemia converted in the euandrogenemia. So estrogen progesterone combined pill is the most important pill. Now hormonal changes, pituitary, ovarian hormones, estrogen, progesterone, ovarian cycle. You see the follicular phase, ovulation, and luteal phase. Endometrial cycle, that is the menstruation, then proliferative and the secretive. So you do this. Now simple thing. Whether the estrogen is estrogen status is good or not, I will say. You can measure directly serum estradiol. That is the estradiol. And you do the progesterone challenge test and endometrial thickness by ultrasound. Endometrial will be thick, estrogen high. If there is no estrogen progesterone, what will the endometrium will be atrophy. Atrophy thickness will be less. No estrogen progesterone. And next is the cervical mucus. For estrogen, there will be abundance of the cervical mucus. Estrogen, estradiol 40 picogram per milliliter suggests presence of the ovarian follicle. And endometrial thickness more than the 6 millimeter, more radical, and the duty is discharge. So estrogen. Most important thing, you will very interesting thing also, that is the progesterone challenge test. Suppose a patient has come to you with amenorrhea, in the oligomenorrhea, amenorrhea, prolonged amenorrhea. He give her progesterone. Suppose what may happen? There may be bleeding and there will be no bleeding. Progesterone you give 7 to 10 days and then withdraw the progesterone. Suppose there is a bleeding occurs. What does it mean? That is the estrogen cannot act without the progesterone cannot act without the estrogen 5 antimeter. She is একা করতে পারবে না। যদি estrogen না থাকে, এটা ক্লিয়ার বোঝো কিন্তু। যদি estrogen না থাকে, estrogen কারণ estrogen ওই রিসেপ্টরগুলো তৈরি করে প্রোজেস্টেরনের জন্য। ও প্রোজেস্টেরন তুমি যদি দাও, যদি নেগেটিভ হয়, এই ইন্ডিকেট করে যে এই ইউটারাস ওভারিটা estrogen প্রাইম নয়, এই এন্ডোমেট্রিয়ামটা। তার মানে estrogen নেগেটিভ হলো। পজিটিভ হলো তার মানে কি হচ্ছে, নিশ্চয়ই ওর estrogen আছে। তাহলে পজিটিভ ইজ এ গুড থিং, কারণ এই estrogen কোথা থেকে আসবে? ওভারির থেকে, গোনাড থেকে আসবে। তাহলে ওভারি ইজ অ্যাক্টিং এন্ড সিক্রেটিং দ্য estrogen hormone, that is the potentially competent, potentially যে ওভুলেশন করানো যাবে তার। ক্লিয়ার তো জিনিসটা? তুমি একটা পেশেন্টকে অ্যামেনোরিয়া আছে 7 থেকে 10 দিন প্রোজেস্টেরন দাও ট্যাবলেট, দেওয়ার পরে 4-5 দিন আগে ওয়েট দেখো, 1 সপ্তাহ ওয়েট করো যে উইথড্রল ব্লিডিং হচ্ছে কি হচ্ছে না। এটা ফিজিওলজি নর্মাল তো। যদি উইথড্রল ব্লিডিং হয় দ্যাট ইন্ডিকেট করে ওর ইস্ট্রোজেন আছে। যদি না হয় তাহলে কি হচ্ছে, ওর যে ইন্ডোমেট্রিয়ামটাই ভালো নেই। সেটা কি কারণ হতে পারে? সাইনেকিয়াতে হতে পারে, তাই না? ইউটেরাইন সাইনেকিয়া হতে পারে, অ্যাসারম্যান সিনড্রোম হতে পারে, এন্ডোমেট্রিয়াম রিসেপ্টর। এই জায়গাটা আজকে টুডেজ ইজ দ্য মেসেজ, টুডেজ লেকচার ক্লাস, দিস ইজ দ্য ইম্পর্টেন্ট মেসেজ ফর ইউর হোল লাইফ। That is the progesterone challenge test. Progesterone challenge test is the progesterone is given for the 7 to 10 days. Wait for few days after administration to observe whether withdrawal bleeding occurs or not. Clear? Next, the positive test bleeding within 2 to 7 days after completion of the progesterone treatment means normal estrogen, and that is the ovary is working. And negative means no withdrawal means suggests endometrium is not estrogen primed. That is the hypogonadism. Estrogen is not secreting estrogen. তাহলে এবারে দেখো এরপরে হাউ আর দেয়ার মে বি ফলস পজিটিভ, ফলস নেগেটিভ। এবং সেখান থেকে অর্থ কি, ধরো এরকম আসবে যে তোমার কিন্তু ক্লিনিক্যালি মনে হচ্ছে না এর ওভারি ঠিক আছে, কোনো মনে হচ্ছে, তখন তোমাকে কি করতে হবে? ইউল হ্যাভ টু চেঞ্জ দ্য টাইপ অফ দ্য প্রজেস্ট্রন। দেয়ার আর সো মেনি ভ্যারাইটিস অফ দ্য প্রজেস্ট্রন। ইউল হ্যাভ টু ডু মোর পোটেন্ট প্রজেস্ট্রন, হ্যাভ টু। ধরো এবার যে নেগেটিভ এলো, তাহলে কি? নেগেটিভ এলো তার মানে ইউট্রাসের ডিফেক্ট তুমি পেয়ে গেলে। এবার পজিটিভ এলো, পজিটিভ মানে কি? ওভারিটাতে ওভুলেশন হচ্ছে না। হ্যাঁ, আচ্ছা নেগেটিভ হলো, এবারে ধরো ইউটেরাইন সাইনেকিয়া বলছো, নেগেটিভ হওয়ার পরে এবার তুমি যদি পেশেন্টটাকে একটা ওয়ে আছে যে দেখার যে ইউটেরাইন সাইনেকিয়া আর ওভারিটা ইউট্রাসের মানে কিছু এন্ডোমেট্রিয়াম আছে কাজ করছে না, অ্যাট্রফি, তখন তুমি ইস্ট্রোজেন আগে প্রাইম করে নাও। তার মানে ইস্ট্রোজেন প্রজেস্টেরন কম্বিনেশন দাও, অথবা প্রাইম করে প্রজেস্টেরন দাও। তার মানে ব্লিড যদি করে, ব্লিডিং যদি হয়, তার মানে ব্লিডিং যদি হয় তার মানে অ্যাটলিস্ট সাইনেকিয়া নয়, তাই না? সাইনেকিয়া নয়, তার মানে ইস্ট্রোজেন ওর কাছে এন্ডোমেট্রিয়াম গ্ল্যান্ড আছে, নাহলে ইস্ট্রোজেন কাজ করছে কি করে? সো প্রজেস্টেরন যদি নেগেটিভ হয় দেন ইউ হ্যাভ টু ডু দ্য ইস্ট্রোজেন প্রজেস্টেরন। এটা ক্লিয়ার তো? সবার কাছে ক্লিয়ার? ইস্ট্রোজেন প্রজেস্টেরন দাও, দিলে এন্ডোমেট্রিয়াম যে অ্যাট্রফি, এন্ডোমেট্রিয়াম যে তার প্রুভ হবে যে অ্যাটলিস্ট ওখানে আছে। এইবারে যদি পজিটিভ হয় তখন তাহলে ডিফেক্ট হচ্ছে যে ওভারি ওভুলেশন হচ্ছে না। কেন ওভুলেশন হচ্ছে না? ওভুলেশনকে কে কন্ট্রোল করে? তা হাইপোথ্যালামিক পিটুইটারি সেই ডিফেক্টে, তাহলে সেই ডিফেক্টে আমরা যাব। তখন আমরা দেখবো যে এফএসএইচ দেখবো যে গোনাডোট্রপিন তার ঠিক আছে কিনা। থাইরয়েড অলসো, থাইরয়েড প্রোলাকটিন আমরা তো রুটিনলি করি থাইরয়েড, তাহলে এফএসএইচ যেটা করবো হাইপোথ্যালামিক পিটুইটারি ওভারে প্রোডাক্টিন ওইখানে কোনো ডিফেক্ট আছে কিনা। ক্লিয়ার? এই যে এক্সট্রা। এবার আমি জাস্ট শুধু বলে দিচ্ছি, দেখো অ্যাপ্রোচ টু সেকেন্ডারি অ্যামেনোরিয়া, অ্যাপ্রোচ টু সেকেন্ডারি অ্যামেনোরিয়া। ইফ দেয়ার ইজ দ্য এক্সক্লুড প্রেগনেন্সি হিস্ট্রি, ক্লিনিক্যাল ইনভেস্টিগেশন, টিএসএইচ, প্রোলাকটিন, এফএসএইচ। হ্যাঁ, এফএসএইচ তুমি এখন নাও করতে পারো, পরেও করতে পারো, কিন্তু এই তিনটে মেনলি করা হয়। টিএসএইচ হাই তার মানে হাইপোথাইরয়েডিজম, হাইপোথাইরয়েডিজম মে কজ অ্যামেনোরিয়া। আবার হাইপোথাইরয়েডিজম মে কজ সেকেন্ডারি হাইপারপ্রোলাকটিনিয়া। সেখানে যদি হাইপারপ্রোলাকটিনিয়াও পাও, হাইপোথাইরয়েডিজম পাও, ট্রিটমেন্ট হবে কিন্তু টিএসএ, এলট্রক্সিন, থাইরক্সিন। থাইরক্সিন দিলেই কিন্তু সবার মাথায় ঢুকছে তো রে? ক্লিয়ার তো? যদি না থাকবে আমাকে বলবি। যে তাহলে তোমাকে কিন্তু তখন কিন্তু প্রোলাকটিনের ট্রিটমেন্ট দেওয়া যাবে না, তখন তোমাকে টিএসএইচ এর ট্রিটমেন্ট দিতে হবে, হাই টিএসএইচ। মানে থাইরক্সিন দিলেই গ্যালাক্টোরিয়াও কারেক্ট হয়ে যাবে হাইপারপ্রোলাকটিনিয়া। আর যদি টিএসএইচ নর্মাল থাকে আর দেখতে যে হাইপারপ্রোলাকটিনিয়া হয়েছে, তখন তুমি তাকে কি দেবে? যে হাইপারপ্রোলাকটিনিয়া হয়েছে তখন তুমি হাইপারপ্রোলাকটিনিয়ার জন্য ব্রোমোক্রেপটিন বা ক্যাবারগুলিন তোমাকে দিতে হবে, ডোপোমেনিট এখন আছে। হ্যাঁ, এই তো ট্রিটমেন্ট হয়ে গেল। আচ্ছা, অ্যাসেসমেন্ট অফ দ্য ইস্ট্রোজেন স্ট্যাটাস ইজ অলরেডি টু দেখতে হবে, কারণ অ্যামেনোরিয়া যখন এসেছে তখন কি করে করবে? প্রজেস্টেরন চ্যালেঞ্জ টেস্ট অলরেডি ক্লিয়ার। প্রজেস্টেরন চ্যালেঞ্জ টেস্ট, উইথড্রয়াল ব্লিডিং পজিটিভ, পজিটিভ মিনস নর্মাল ইস্ট্রোজেন। নর্মাল ইস্ট্রোজেন মিনস যে ওর ওভুলেশন হচ্ছে না, ওভারিটা নর্মাল আছে কিন্তু ক্রনিক ওভুলেশন, টিপিক্যাল ফিচার অফ পলিসিস্টিক ওভালেশন। আচ্ছা, উইথড্রয়াল ব্লিডিং নেগেটিভ, নেগেটিভ মিনস লো ইস্ট্রোজেন, তার মানে ইস্ট্রোজেন সিক্রেশন হচ্ছে না ভালো। তখন কি করবে? ইস্ট্রোজেন প্রজেস্টেরন চ্যালেঞ্জ টেস্ট করবো, চ্যালেঞ্জ টেস্ট করবো। ইস্ট্রোজেন প্রজেস্টেরন চ্যালেঞ্জ টেস্ট করলে নেগেটিভ, নেগেটিভ তাতে অ্যাসারমেন্ট সিনড্রোম, তার মানে সাইনেকিয়া হয়েছে। তখন ভালো করে হিস্ট্রি নাও, কি করে সাইনেকিয়া, দুটো ইম্পর্টেন্ট কারণ, ভিগোরাস কিউটিং আর টিউবারকুলোসিস। হ্যাঁ, আচ্ছা, তখন আমি হিস্টোস্কোপ করে দেখবো যে সত্যিকারের ডিগ্রি অফ সার্ভিস। আর পজিটিভ যদি হয় ধরো এটা পজিটিভ হলো স্টেন পজিশন, তার মানে পজিটিভ হলো মানে আমার ইউটারাসটাকে ছেড়ে দাও, ইউটারাস আর দরকার নেই, আমি বুঝে গেছি যে ইউটারাসটা পজিটিভ মানে ইউটারাসটা ঠিক আছে, তাহলে পজিটিভটা হচ্ছে, তার মানে যে হচ্ছে তখন আমি এফএসএইচটা দেখব, কারণ হায়ার এফএসএইচ যদি ওভারিয়ান ফেলিওর থাকে, তাহলে ওভারিয়ান ফেলিওর থাকলে কি এফএসএইচ হাই হবে, হাইপার গোনাডোট্রফিক হাইপোগোনাডিজম, হাইপার গোনাডোট্রফিক হাইপোগোনাডিজম, এফএসএইচ সিক্রেশন হচ্ছে না, that may cause in the pituitary or that may cause in the hypothalamus, and MRI brain prolactinের জন্য MRI brain করা হয় যে hyperprolactinemia আছে কিনা, if the ovarian failure যদি হয় তাহলে that is the premature ovarian insufficiency হতে পারে, that genetic disease, তোমাকে ক্যারিওটাইপিং, অটোমিউন ওয়ার্কার, FM RY অন একটা টেস্ট করতে হবে, MRI ব্রেন যদি হয় হাইপোথ্যালামিক অ্যামেনোরিয়া হতে পারে, পিটুইটারি অ্যামেনোরিয়া হতে পারে, এমন কোনো লিসন তুমি হাইপোথ্যালামাস অর আদার দেন দ্য পিটুইটারি অ্যামেনোরিয়া। নাও আই কুইকলি go through the management. This is actually one single chart you will get from the book, you will get from the book. See that single chart, you will just today my request you to see the chart only. If you understand the chart, that is okay. If there is any confusion, you say, you see the chart, that is the chart in the single the flow chart of the hyperprolactinemia. This is the less than the 1% among the general population. In secondary amenorrhea cases, as high as 30% secondary, and infertility cases 30%. With galactorrhea and amenorrhea 50%. Causes of the hyperprolactinemia. Common is the physiological. The prolactinoma 50 to 60% cases, and drug I already said described, hypothyroidism 3 to 5%, and others such as the ectopic endometrium, chronic failure. So that is the important message is that one thing is the during the management, if the thyroid level there is a hypothyroidism, that the TSH is high and also the prolactin is high, you treat for the hypothyroidism. If the TSH is normal and prolactin is high, you confirm whether there is really a prolactinoma, then you will give the bromocriptine or the carbamazepine. And prolactin level normal, which is normal 20, but so many diurnal duration of the prolactin level, so you will be very cautious, multiple time you will take. And hook effect, their MRI and prolactin, MRI should be performed whenever prolactin level is persistently elevated. Mild prolactin level may be associated with other organic CNS disease. Macroadenoma, microadenoma, and macroadenoma more than 10, and microadenoma less than 10 millimeter. And microadenoma rarely progresses to the macroadenoma. Microadenoma is rarely associated with the 200 nanogram per milliliter. Hyperprolactinemia and galactorrhea. It's a very on all cases of galactorrhea, there need not be hyperprolactinemia. In all cases of hyperprolactinemia, there may not be galactorrhea. So that is also very important. If there is a galactorrhea ammonia, that is called galactorrhea ammonia syndrome. That will get a short note also. Galactorrhea ammonia syndrome. And how does amenorrhea? It will read from the book. Amenorrhea causes the prolactinemia. I am not going into detail. Treatment is dopamine agonist, bromocriptine and gabapentin. Surgery is done in refractory tumor, and you will have to do refractory tumor and large tumor, and you will have to do the transperineal approach. You defer to the neurosurgery. And radiation is given surgically sometime. And thyroid disorder, that is very important. I already said what is the thyroid disorder. Hypo and hypothyroidism may cause abnormality. Hypo usually the amenorrhea, oligomenorrhea, and thyroid and the thyrotoxic hyperthyroidism is usually the irregular vaginal bleeding. Mechanism, that is mechanism actually why there is a hyperprolactinemia in case of hypothyroidism. Decreased thyroid hormones by the compensatory mechanism increases TRH level, and this TRH in turn increases TSH as well as the prolactin levels, and the prolactin secretion by binding pituitary gonadotropin. In hypothyroidism, prolactin is usually does not rise more than 100. Normal is 20, 30 we consider is 30 to 35. If there is a more than 100, you always do the suggest repetitive persistent, you always do the CT scan of the brain. আচ্ছা প্রিমেচার আমি মনে হচ্ছে লাস্ট পার্টটা পরে আরেকদিন পড়ে দেবো, কারণ এখানে খুব সুন্দর জিনিস আছে। প্রিম্যাচুর ওভারিয়ান ফেলিওর আর পলিসিস্টিক ওভারিয়ান সিনড্রোম, দু তিনটে জিনিস শুধু একটা জিনিস আমি বলে দিচ্ছি। পলিসিস্টিক ওভারিয়ান সিনড্রোম এটা যাচ্ছি না আজকে, আর এটা আমি আরেকদিন তোদের পড়াবো। হ্যাঁ, খুব ইন্টারেস্টিং। এই যে এইটা বললাম হাইপার একান্তোসিস নাইগ্রিক, আলাদা পেশেন্ট, সব পেশেন্টই নিজস্ব পেশেন্ট। সোনোগ্রাফি পিসিওএস, যে এই যে এইটা মনে রাখতে হবে, 20 or more antral follicle, 2 millimeter to 9 millimeter। হ্যাঁ, আর কোনো কিন্তু পলিসিস্টিক ওভারিয়ান সিনড্রোমের কোনো কিন্তু হরমোনাল মার্কার এবারে অবভিয়াস রিকমেন্ডেশন নেই যে এই হরমোনটা বেশি হলে এটা হবে। এটা মাথায় রাখবে, যে যাই বলে থাকুক এটা কিন্তু মাথায় রাখবে। যে অনেকেই বলবে যে এই হরমোনটা, ডোন্ট জাম্প ইন্টু দ্য সো মাচ হরমোনাল। দিস ইজ দ্য থিক অ্যান্ড কমপ্লিকেশনস অফ পিসিএস ম্যানেজমেন্ট আউটলাইন। ল্যাপারোস্কোপি ড্রিলিং, সার্জারি হচ্ছে ল্যাপারোস্কোপি ড্রিলিং করা হয়। অ্যাসারম্যান সিনড্রোম, এই অ্যাসারম্যান সিনড্রোমটা বলে শেষ করে দেবো। ভিগোরাস ইউরেটেড পিপিএইচ, মিসক্যারেজ, এমটিপি, এন্ডোমেট্রাইটিস হতে পারে, ফলোয়িং মেট্রোপ্লাস্টি, মায়োমেক্টমি, ডায়াগনোসিস ইউএসজি, স্যালাইনোস্কোপি, এইচএসজি, হিস্টোস্কোপি। ট্রিটমেন্ট অ্যাকচুয়ালি অ্যাসারম্যান সিনড্রোমের ভেরি ডিফিকাল্ট। ট্রিটমেন্টের ভেরি ডিফিকাল্ট। ইউ উইল হ্যাভ টু সাইনক্লোলাইসিস, হিস্টোস্কোপি করে ট্রাঙ্কুলাইসিস করতে হবে। করার পরে তুমি ইস্ট্রোজেন প্রোজেস্টেরন দাও। ইস্ট্রোজেন পাইপ ওঠার জন্য ফার্স্টে ইস্ট্রোজেন, তারপরে ইস্ট্রোজেন প্রোজেস্টেরন লং দাও। আর ওখানে আবার যেহেতু না হয় সেজন্য আমরা করে কি একটা আইইউসিডি দিয়ে দিই, ইন্টারডেন কন্ট্রাসেপ্টিভ। তুমি 6 মাস দাও, সাইক্লিকে ইস্ট্রোজেন প্রোজেস্টেরন দাও, এন্ডোমেট্রিয়াল ফরমেশন হতে পারে। মাথায় রাখতে হবে যদি ইউটেরাইন সাইনিকার করে প্রেগন্যান্সি যদি হয়, that what will happen at the endometrium is there is a chance of the adhesion of the placenta. There is the placenta accreta spectrum. Placenta accreta হতে পারে, এটা সবসময় মাথায় রাখতে হবে। It is very difficult to treat, and also tuberculosis is very difficult to treat. And at least you do the tuberculosis to like the, so that leave the patient healthy. That is very important. This is the uterine sonic sonography. The prevalence of pathological amenorrhea is 3 to 4%. 4 most common causes are PCOS, hypothalamic amenorrhea, ovarian failure, and hyperprolactinemia. History, physical examination, estimation of TSA, prolactin FSH. Logical stepwise approach enables to reach the final diagnosis in almost all cases. Management is according to the cause. Thank you all.